Good morning. Good morning, everyone, and bon appetit. My name is Amit Bar-Or from the University of Pennsylvania, and on behalf of my co-chair, Dr. Tanusha Chitnis from the Mass General Brigham, we are delighted to welcome you to this peer-review live event on neuroinflammation in focus, interpreting the latest evidence for BTK inhibition in multiple sclerosis. And so we're delighted that the show out is as good as it is. This is hopefully going to generate some great questions and a fun discussion at the end. We'll go through a number of slides and batter back and forth between Tanusha and myself, and eventually hope to field questions that you will have. We want to thank PeerView, perhaps not for all those extra letters behind our names, but certainly to PeerView and to Sanofi for providing the support for this. Also, PeerView offers a website, and after the meeting you'll be able to access the slide practice aids as well. And you can see, and we'll see again at the end, the email as well as the social media connections that PeerView offers. So our goals for today are to learn about current modifying therapy shortcomings in the context of addressing, in particular, this concept of progression independent of relapse activity, or PIRA. We'll briefly talk about the biological rationale. I'm sure you've all heard a lot about the rationale for BTK inhibition in MS in terms of targeting immune and CNS pathways, with the view that maybe we'll be able to address both relapsing biology and the more compartmentalized CNS inflammation that is considered to be at least one important driver of non-relapsing progression in patients with MS. And finally, thinking of strategies that may help us tailor future treatments by aligning the selection of therapies with the evidence and really thinking again of evidence-based but more precision medicine approaches to thinking of this particular aspect of CNS compartmentalized neuroinflammation. So we'll start with this question. So in your practice, which of the following represent the challenge for you in your clinical decision-making for the treatment of individuals living with MS? And you can select all that apply to you. 1, incorporating patient preferences and values when choosing a therapy. 2, identifying the optimal time to initiate high-efficacy therapy. 3, recognizing the best time to switch to a different therapy. 4, ensuring therapy adjustment will not result in rebound disease activity. And 5, choosing a therapy that is most likely to achieve multiple treatment goals, which would include decreasing relapse activity and delay progression. So please go ahead. Okay, so what we're seeing here, it's still building a little bit. We'll give it a moment. But quite a few people consider it challenging to recognize the best time to switch to a different therapy and choosing a therapy that's most likely to achieve the combination of impact on relapse disease and progressive disease. But people consider some of the other issues also challenging, although seemingly less so. And I think that that's actually a very good backdrop to this particular presentation, that is dealing with the major unmet need of tackling the non-relapse progressive biology of MS and how to apply that in the clinical setting. And so the unmet needs here, just to elaborate a little bit more, are that we have this concept of people getting worse clinically, reporting to us that they're worse in ways that we sometimes are not that good at measuring, and therapies that we have today, for the most part, are not really tackling this aspect that we, at least in part, attribute to CNS compartmentalized inflammation. Of course, to achieve an impact on that, we have to have therapies that access the CNS, and again, for the most part, most of the treatments that we've been applying in the periphery to date have not really achieved that. We also have challenges in terms of our ability to monitor, and we recognize deficiencies, of course, in the EDSS and other of the more formalized measures. Conventional MRI as well teaches us a lot about focal lesions, but doesn't yet do a great job in terms of the non-focal, more distributed CNS compartmentalized processes that we want to capture for PIRA-type considerations. And we need something that is going to be targeted, that is tolerated, that is going to be sufficiently safe. And in this context, and this session is really focusing on the prospect that BTK inhibition with BTK inhibitors may offer, in some contexts, a selective CNS penetrant modulation with a manageable safety profile. And of course, the goal here is to try to limit what people end up with is a persistent disease burden with disability accumulation and a compromise on quality of life. And the way that we as a field are trying to do so is to consider some of the emerging monitoring strategies to do better than we're doing now to capture this aspect of the MS biology, and of course to develop therapies aimed at targeting it. A challenge is, and it's almost like having too many variables and not enough equations, until we have a treatment that definitely impacts this biology, it's difficult to develop ways of measuring that biology and how it's being impacted. So I think we're now a little beyond the cusp of that, and it's an exciting, although still challenging time for us. Now we're going to be thinking together about Lisa throughout this presentation, so I'm going to present her briefly now. But Lisa is a 52-year-old who's coming to you for her first visit in your MS clinic, though she has a 12-year history of an MS diagnosis, and there's a sense that she's been getting worse gradually over the last few years. She's had no obvious relapses in the last 4 years, but definitely feeling more fatigued, having more bladder symptoms, and having increased difficulty with her walking and endurance. She has hypertension and a history of depression. She works in human resources and has had some increasing difficulty over the last year in terms of some cognitive tasks in the workplace. She tries to remain active, but finds it frustratingly limited because she's too fatigued. Her MRI, notes that you get and images that you can see from previous neurology follow-ups, are stable over the last years. She has, according to your measurement today, what appears to be an increase in her 25-time-foot walk, and her EDSS seems to have increased also in this range where it's mostly attributed to increasing gait difficulty. She had been treated for relapsing MS, having presented initially with several relapses, had been on gluteramine acetate for some years, but was off therapy for the last few years and had opted to stay off, having been monitored and not having any evidence of relapsing disease, and not particularly being keen on treatments, especially being told that there aren't really treatments particularly well suited for her profile. And with this patient in mind, I'm going to shift things to Dr. Chitnis, who's going to tell us about shifting goalposts. Please, Tanusha.
Great. Well, thank you, Amit, Dr. Bar-Or. So I think what is becoming clear is that we have an increasing understanding of MS pathophysiology, and this evolving conceptual framework involves what we currently know as focal lesions. So these are our acute gadolinium-enhancing lesions, T2 focal lesions that occur particularly in the early stages of relapsing remitting MS. These do persist throughout, but we now have an increased understanding and appreciation of compartmentalized inflammation, which includes chronic lesions, meningeal inflammation, and cortical pathology. So I think this has now been highlighted very well through a number of imaging studies as well as clinical and pathological studies. And what is also important to recognize is that inflammation plays a role in both of these processes, both the focal inflammation and the compartmentalized inflammation, but a different role in different stages of disease. So we've traditionally thought about MS as relapsing MS and progressive MS, and relapsing is driven by peripherally mediated inflammation, and a growing understanding that progressive MS is associated with compartmentalized inflammation with neurodegeneration. However, I want to just bring to you another paradigm, is that these processes are interspersed and that these processes are happening across the MS spectrum. So we have relapses in the early phase. We also have PIRA, or progression independent of relapses, in the early phases of MS. These can occur, and we've now shown this through several studies. In addition, in the later stages, what we traditionally think of as the secondary progressive stage, we can have relapse-associated worsening as well as progression. So these processes are interspersed across the whole MS spectrum. So what are these definitions? So what is PIRA, progression independent of relapses? Is disability accumulation occurring without clinical relapses. And although subclinical inflammation can be present, and this is again the compartmentalized inflammation. In contrast, in addition, actually, I should say, PIRMA is when we really drill down on this definition and also include MRI activity. And so this is PIRMA is disability accumulation occurring without clinical relapses or MRI activity, such as new gadolinium-enhancing lesions or new T2 lesions. So these are, important concepts to keep in mind throughout. Now, what is also becoming clear is that PIRA is a primary driver of disability accumulation in MS. And I was quite surprised when I saw this figure, the first figure, that in 20 years, up to the 20-year mark, about 50% of our patients will have evidence of PIRA. And then also what is becoming increasingly recognized is that those patients who have early PIRA, so PIRA within the first 5 years of their disease course, will have about a 26% increase in their EDSS worsening. So again, PIRA is associated with a more severe EDSS and worsening disability. So we now have a number of measures to measure disability, and these include our traditional measures, EDSS, things like 9-hole peg test and time 25-foot walk, as well as some of our cognitive measures, SDMT and others. But we also have a number of emerging measures for disability accumulation, and it's quite exciting to see a lot of work being done on fluid biomarkers, on a number of MRI metrics, including PRL, spinal cord volume, also measuring what the patient reports, so PROs, and using digital tools to really understand what is happening with our patients in between visits. So it is indeed a very exciting time in terms of new measures. Now, paradigmatic rim lesions have emerged as a very important predictor of a more severe MS disease course, and this has been associated with a more severe course of MS in several studies, and in fact made it into the 2024 NAMES consensus. And we also know PRLs are important for MS diagnosis, and of course are incorporated into the new MS diagnostic criteria. So this is driven by smoldering inflammation in the CNS or in the form of chronic active lesions. So there are also a number of promising biomarkers. We know that, of course, oligoclonal bands are important in multiple sclerosis, but a number of other factors are emerging as important, potentially measurable biomarkers in the serum or CSF. We have NFL, we have GFAP, but also a couple of other inflammatory markers, such as CXL13, which is important for the recruitment of lymphocytes into the CNS, something called osteopontin, which is a cytokine that is secreted by activated immune cells, and other measures that may be incorporated into panels at some point to help us understand relapses versus progression. So now, with that framework, I'll now turn it back over to Amit, who's going to give us an update on the latest safety and efficacy data in BTKs.
Thanks, Tanusha. So this is not going to be a comprehensive overview of everything that you've already seen or heard of, but hopefully we'll set the stage for us thinking about Lisa and for some of the question, answer, and discussion that we'll have. Of course, the prospect that BTK inhibition will do something meaningful in multiple sclerosis is based on the recognition that BTK, the target of BTK inhibition, is upregulated during activation and necessary for a variety of cellular functions, particularly in B cells and in myeloid cells of the immune system. And here on the left, you see the B cell. You see BTK inside it as a kinase that is involved, again, in downstream signaling pathways. When you inhibit it, you decrease a variety of B cell responses, including their maturation, their proliferation, and several effector functions, including antibody production and cytokine secretion. And in the context of myeloid cells, which include CNS-resident microglia, one of the ways for BTK to get activated, and it's been indeed shown to be abnormally upregulated within the CNS of MS patients, is through the Fc gamma receptor of the myeloid cells, but there are several others, including potentially toll-like receptors. And their BTK inhibition will result in decreased activation of the microglia, and particularly decrease in the release of a variety of what would be viewed as inflammatory mediators, including some of these inflammatory cytokines, TNF-alpha, IL-1 beta, and IL-6. So the prospect of targeting these cells, both in the periphery for B cells and peripheral myeloid cells, and within the CNS for B cells that infiltrate and we know set up shop there, and importantly for microglia, is really the backdrop for us thinking about BTK inhibition as an attractive approach in the context of MS treatment, because here, at least with CNS-penetrant BTK inhibitors, you have the prospect of impacting, with the peripheral administration, biologies that are relevant both for relapsing disease activity and hopefully also for non-relapsing progressive disease. And again, the notion of having to get across the blood-brain barrier is one very important feature, and we probably have already seen this in the context of BTK inhibition, as some do and some do not have evidence of getting into the CNS and getting in at concentrations that would be viewed as biologically relevant in terms of the PD of molecules. Great. So this is a reasonable summary of the landscape of phase 3 clinical trials of BTK inhibitors pursued in MS. You can see 4 of the BTK inhibitors on the left-hand side: tolebrutinib, fenebrutinib, remibrutinib, and orelabrutinib. And you can see trials that are done in relapsing MS, in secondary progressive MS, and in primary progressive MS. And of particular interest for today, of course, are the ones that are involved in the progressive forms of multiple sclerosis. And I'll talk about some of those completed trials, and again, relatively top level. And it's reassuring to know that as we've been learning and getting excited about the prospects of BTK inhibition, we still face some challenges, but we also have some ongoing trials that we won't have a chance to talk about today, also addressing both SPMS and PPMS. And so I'm going to go through a few of these with the trial design and basically the top-line results. Hercules was, of course, the phase 3 tolebrutinib trial in non-relapsing secondary progressive MS. So individuals were recruited with a clinical diagnosis of SPMS. They had to have no clinical relapses within the 2 years prior and have evidence of disability progression within the last year, with an EDSS range, as you can see, between 3 and up to 6.5. The trial was a 2-to-1 parallel arm randomization of tolebrutinib, the 60 milligram daily dose, versus placebo. And the blinding went on from between 24 to 48 months. And patients continued until this event-driven study achieved the pre-planned 288 events of the primary outcome measure, 6-month confirmed disability progression. And this is the primary outcome of the Hercules trial, showing an impact on disability with tolebrutinib versus placebo. You can see there a 31% reduction. You can see an early separation of the curves and what appears to be perhaps further separation of the curves over time, although one always has to be a little cautious about the latter time points where you can see underneath the graph fewer and fewer individuals contributing and less confidence about the exact numbers that you get. But this study shows that participants with non-relapsing SPMS treated with tolebrutinib experienced significantly lower confirmed disability progression compared to placebo. And these are the secondary disability endpoints, outcome measures. This was a hierarchical assessment, so you can see that the 3-month confirmed disability progression, as opposed to the primary, which was 6-month confirmed disability progression, was also met with a hazard ratio of 0.76. But as far as the 9-hole peg test, this did not achieve significance. So the ones below, although their hazard ratios are appealing, they can't be commented on with the same kind of statistical significance. But what they show nominally is that there were fewer people on tolebrutinib who had a 20% or more increase in the timed 25-foot walk with a hazard ratio of 0.77, and there were more people on tolebrutinib who achieved confirmed disability improvement at 6 months with a hazard ratio of 1.88, also not crossing a unity. The 2 phase 3 trials of tolebrutinib versus teriflunomide in relapsing MS were Gemini 1 and Gemini 2. Individuals with relapsing MS between 18 and 55 had to have evidence of some focal disease activity, either clinically, relapses, or relapse biology, if you like, in terms of MRI, with an EDSS of up to 5.5. Again, a parallel arm, in this case 1-to-1 randomization of tolebrutinib versus teriflunomide, double-blinded, of course. And the blinded treatment here again, in this case, 18 to 36 months, also an event-driven trial with confirmed disability worsening, with a view that each of these trials would report on its own with respect to relapsing outcome measures, annualized relapse rate, but that the analysis of disability worsening would be done as a combined pooled data set. And so here you see the comparison of the effects of tolebrutinib versus teriflunomide on the annualized relapse rate, and Gemini 1 on the left, Gemini 2 on the right, and you can see that, in fact, there was no significant impact or benefit for tolebrutinib over teriflunomide. But interestingly, in the face of not showing a benefit with respect to annualized relapse rate, you do get separation of curves on the Kaplan-Meier curve in terms of time to 3-month confirmed disability worsening and time to 6-month confirmed disability worsening with the tolebrutinib versus the teriflunomide. And so this, together with Hercules, and again, even though in this hierarchical analysis we need to be again cautious about the disability worsening data, nonetheless, in my view, gives us a picture of an agent that seems to have an impact on worsening disability over time in the face of not being superior to the drug that it's compared with in Gemini with respect to relapse rate. And this is really, in my mind, what has provided a sense that this drug is doing something that's different in the sense of impacting, presumably through the access to the CNS, perhaps activated microglia, perhaps B cells, and impacting the progression of disability that is not relapse associated. Safety profile, of course, very important, and at Hercules, there was an increased rate of some treatment emergent adverse event, 15% in tolebrutinib versus almost 10.5% with a placebo. There were 3 deaths overall, 2 in the tolebrutinib arm, and one of those deaths, well, one was not assessed as related, one was assessed as related to tolebrutinib, and it was in fact a liver enzyme complication with post-operative liver transplant complications. Otherwise, there was a slight increase in some typical infections, as we've seen with other effective MS therapies over the years, a slight increase in terms of respiratory infections, but nothing unusual in this patient cohort. The liver safety profile is shown here for Hercules, and you can see at the bottom the different levels of fold increase over the upper limit of normal of the ALT. And across all the different ranges, you can see more such events with tolebrutinib as compared to the placebo. The ones that are of greatest import in terms of the potential safety issues are the ones farther to the right, where you can really see, although very small frequencies, that this is happening with tolebrutinib, but not in placebo. And these are the ones farthest on the right, 0.4% meeting at least a biochemical Hy's Law's definition, which is the one that has raised concerns. And the idea of mitigating the risk by being able to identify rises early and then responding to that to avoid the risk is something that had been implemented subsequently without further such more serious outcomes in this trial. The safety data pooled here for Gemini 1 and Gemini 2, overall actually pretty balanced between the two groups. Again, maybe a signal here in terms of infection and nasopharyngitis, but not much more in terms of other particular outcomes. And there were 3 deaths across the 2 treatment groups, 2 in the teriflunomide, 1 in the tolebrutinib. That was actually a homicide, so not considered related to the drug. Liver safety for Gemini, what you can see here, unlike what you saw in Hercules, is that as far as the lower fold increases in upper limit normal, where there's no difference between tolebrutinib and teriflunomide, of course, itself known to be associated with some bumps in liver enzymes. But what you can see again on the far right is that tolebrutinib, very small percentages, but nonetheless higher than the teriflunomide. Moving on to PPMS, the Perseus trial, phase 3 of tolebrutinib, looking at tolebrutinib versus placebo. This was a cohort of individuals who were diagnosed with primary progressive MS, had to have positive CSF OCBs and or elevated IgG index, and their EDSS could go up from 2 to 6.5. Here the primary endpoint, again, time to onset of 6 months, but confirmed disability progression on a composite, the composite that is typically used, which includes an EDSS 25-timed foot walk and 9-hole peg test. And the parallel arm design, nothing particularly unusual about the design of the study, with again the 6-month confirmed disability composite as the primary outcome. And as you've heard, top line, tolebrutinib did not reduce disability accrual in patients with primary progressive MS in the Perseus study. So the primary endpoint of delaying time to 6-month composite confirmed disability progression was not met. Phenopta is taking us into the fenebrutinib, and while we don't yet have data to really look at in terms of the impact of fenebrutinib in relapsing MS, we do have the results of the phase 2 trial, which were intriguing and different from phase 2 data that we had with prior BTK inhibitors. This was a pretty simple placebo-controlled 2-to-1 randomization looking at fenebrutinib versus placebo in a population of individuals with relapsing MS enriched for having disease activity prior to study entry. I won't belabor this, but the primary endpoint was going to be based on GAD lesions, and what you can see on the left-hand side is the primary outcome, which was the mean number of new GAD lesions combined for weeks 4, 8, and 12 on this 12-week placebo-controlled trial. So that was the statistically significant reduction there. When you look to the right at the breakdown of the different epochs, you get a sense that perhaps an early onset of effect at week 4, but certainly by week 8 and 12, a very substantial effect on limiting this measure of relapse biology. And that had certainly raised the question as to whether there may be some differences between fenebrutinib's impact on relapsing disease as compared to what had been seen with tolebrutinib and previously with evobrutinib. The safety profile of fenebrutinib in this relatively small trial with a 2-to-1 randomization, there was nothing particularly new to comment on other than more discontinuations in fenebrutinib, most driven, as you can see, by the abnormal liver enzymes, and again, perhaps a little bit of a signal with respect to low-level infections. There are going to be data presented in a subsequent meeting that will pull together the FENHANCE-1 and FENHANCE-2. These are the two identical large phase 3 trials of fenebrutinib versus teriflunomide in relapsing MS. Again, a cohort of individuals enriched for some prior disease activity and looking at the ability to perform 9-hole peg test as indicated there with an EDSS range of 0 to 5.5. The key primary endpoint will be annualized relapse rate. What you have heard of already are the top-line results of FENHANCE-2, which showed a reduction of ARR compared to teriflunomide in this population of relapsing MS. And of course, one looks forward to see the results of FENHANCE-1 with a planned joint presentation of those data, as I mentioned, down the road. FENtrepid, an interesting study that pitted fenebrutinib against ocrelizumab, the approved therapy in primary progressive MS. A large study, just under 1,000 patients, individuals with PPMS clinically who had disability progression again in the prior 12 months. And here the primary endpoint, time to onset of 12-week composite confirmed disability progression. In another parallel design, one-to-one randomization, in this case of fenebrutinib versus ocrelizumab, done in a double-blinded fashion. And this is sort of partially event-driven in the sense that everybody had to have at least 120 weeks of exposure or to meet the endpoint based on the number of individuals hitting the endpoint. And here, I'll have the privilege of presenting this data actually tomorrow also at the late-breaking session. So don't miss fenebrutinib in PPMS head-to-head with ocrelizumab. So this is another way of depicting the landscape. And the reason to show this is that, as I mentioned, we are at a pretty exciting time, in my view. We've had results come out and coming out of phase 3 clinical trials of BTK inhibitors, including CNS-penetrant BTK inhibition in populations with progressive MS, SPMS, and PPMS. And we have several others, as you can see to the right at the bottom, that are ongoing, and more data will come in. And the excitement has also involved some challenges, some hiccups, and this is, I think, something that we're definitely going to want to talk about in the Q&A. I'm going to pass the baton back on to Tanusha, who will talk about potential role for BTK inhibitors in our clinical patients. Thank you.
Great. Thank you, Amit. So I think now that you've heard at least the top-line clinical trial results, the recent results, as well as what is available in the literature, let's go back to our case. So as you remember, Lisa, she's our 52-year-old woman who's presenting for an evaluation in your clinic for the first time. She has a 12-year history of multiple sclerosis with evidence of progression. And she has had no relapses in the past 4 years. She's been on glatiramer acetate in the past, but not currently on treatment. And she's also has been reporting worsening fatigue symptoms, bladder dysfunction, cognitive issues at work. And her EDSS is currently 4. And her time 25-foot walk has increased about 25% since her diagnosis. So thinking about this case, and we'll go to our questions, what would you recommend as a next step if all of these options were available? And going through the options of a fumarate, alemtuzumab, natalizumab. So please answer. Okay. Well, these results are very interesting, and I think an anti-CD20 is certainly emerging as one of the options, and a BTK inhibitor is emerging as one of the top options. So let's see, these are very interesting results, and we'll go to the next slide. And I think as Amit had described, there are a number of different BTK inhibitors that are either completing or have ongoing clinical trials. And we think of BTKs generally as a class. However, there are emerging differences in both the pharmacokinetics and dynamics of these agents, as well as the safety and efficacy data that is being now reported. So in terms of differences pharmacokinetically, there are differences in reversible or non-reversible binding, covalent and non-covalent interactions. CNS penetration is certainly something that I'm keeping an eye on and very interested in how these work, and as well domain targeting. And all of these could affect their selectivity as well as ultimately tolerability and efficacy. So there may be meaningful differences between the different molecules in the BTK inhibitor class, and these might eventually translate into what we'll see in clinical trials. So keeping all of this in mind, we're going to ask you to answer an additional poll question on how you would manage Lisa's treatment. Okay, I don't see the results of that. Okay, we should move on. Okay, I guess maybe the results will become available afterwards. So I think we'll maybe just open it up for a little bit of a discussion. And Amit, interested in your thoughts. What if this patient had been on a fumarate instead of being untreated or on a platform therapy initially?
So this is an individual who, in spite of being on a drug that is, let's say, moderately effective against relapse biology, is progressing, right? We don't know whether the person is not having relapses because they're on treatment, and this is even more of a conundrum with higher efficacy therapies. But we know that the individual is progressing, and we're attributing this. It's always a challenge to know whether this is related to some relapse biology that is not fully controlled, although this person had MRIs as well, and there's a sense that really no new focal lesions nor clinical relapses. I wouldn't necessarily think of this person differently. I think that this person is someone who seems to have an important aspect of non-relapsing progressive disease, and if I had a therapy that could control that, and particularly if it had a profile in limiting relapse biology as well, this would be a therapy that I would consider very reasonable to discuss.
Yeah, and I think certainly all the options that had been brought up in the last poll are on the table, but I think I would be very interested in an agent that could both affect relapsing biology, as well as pure or progressive biology. I think another sort of information that I would like to have is also maybe additional biomarkers and MRI features that could inform these decisions, and these might also become available through our clinical trials. And I think NFL is certainly rising to the top as one of the biomarkers associated with relapses, GFAP potentially with PURE, and we might see more coming down the pike. Meet your thoughts on additional biomarkers that might help you inform this decision of whether to switch from DMF to another agent, potentially a BTK inhibitor?
Well, I think that you pointed out before to paramagnetic rim lesions, and of course where they may be useful here is to be able to get a sense that the biology of interest is there. And of course, we have not yet been able to identify a way to use pearls in the way of monitoring people over time, and that's something that may or may not be achieved. But the presence of that imaging measure is an indication that the biology of interest, or at least part of the biology that's been associated with CNS compartmentalized inflammation, is there. If you don't see them and you're struggling with a decision between treatments, you're going to want to keep the person from having relapses, and that's, I think, an imperative that all of us now with sort of the new MS feel people should not be having even small numbers of lesions over time. We should be able to control that in just about everybody. So we need to be cautious about thinking of tackling non-relapsing progression if it's at the expense of preventing new lesions from developing. But the goal, and I think your point, is that we need to do better in terms of identifying these biologies under the surface in order to be able to understand the extent to which they may be contributing to individual people as part of the decision making.
Yeah, no, great. I absolutely agree, and I think that imaging biomarkers will be very, very helpful. We said that Lisa had early secondary progressive MS. What if she was, say, 5 years into the disease and had relapsing remitting MS, maybe was on a platform DMT? Would you approach her treatment differently if she now came to you reporting symptoms of what we consider pure progression, worsening fatigue, difficulty with cognition, and possibly with gait?
Yeah. If she's on a modestly or moderately effective therapy against relapsing disease, I would try to look hard to see, is it controlling enough? I think one of the issues is that when we say that someone has PIRA, because we could not attribute the worsening over time to relapses clinically, we may not be capturing everything, and that's why you made the point that adding the MRI to look at whether you can attribute more is important to do. At the same time, the presence of relapse biology that may contribute to people getting worse doesn't preclude the presence of non-relapsing progressive biology. And as you pointed out as well, we now believe that both of those processes are occurring in most people, overlapping by decades, and certainly the evidence that pearls are present as early as you look, including in radiologically isolated syndrome, in pediatric MS, the biology is there, unfortunately, much earlier than we would like to see it. And if we had safe treatments that could be applied without compromising control of relapsing disease, one would definitely, I think, a reasonable consideration is applying them very, very early in the course of MS, because the biology is already there.
Yeah, I absolutely agree with all of these sentiments, and I think that early biology, I think we now are increasingly recognizing, has a mix of pura as well as relapsing biology. And I think it would be great to have an agent that did both, suppressed both relapses and pura, and was well tolerated and safe. So I think all of these options are on the table, and we're going to be interested in the audience's thoughts as well eventually. Another question that is emerging is, what if this patient had been on B-cell depleting treatment for the past 5 years and had suppressed relapses, was doing well clinically, but now has been experiencing frequent URTIs, UTIs, infections, and she's asking for a different drug, a different agent, and is really, a little bit, has not done well on the B-cell therapy from a safety standpoint. At this point, would you consider switching to a BTK inhibitor if it becomes available?
And this is an individual who is getting worse in terms of what you think maybe...
Let's say for the first scenario that they're not getting worse clinically, but really are just looking for a switch just based on adverse event profile.
So I think that this type of adverse event profile certainly should warrant thinking of a switch. There are some discussions about switching from one anti-CD20 to another, but perhaps something else that people are very different, I think, immunologically, including those relatively few people who turn out to be susceptible to one or more of these treatments. Most people on anti-CD20 for a good number of years will not experience this, but some clearly do. I do think, though, in the scenario of someone who's getting worse, and that's where the question of the BTK inhibitor, particularly CNS penetrant ones, would come in. I like this transition biologically, actually. I think that there's some really good rationale to think of it biologically. The one issue would be, is this person, again, someone who you were concerned about for a relapse history that was severe and frequent, and you think that they are not having relapses because they're on a high-efficacy therapy? What happens if you transition? And if you do so to a BTK inhibitor, obviously you need to consider the profile of that BTK inhibitor with respect to the impact on relapsing disease activity. But one of the considerations has been now, as we've had more and more experience with stretching out intervals and even some discontinuation type studies that are considering that perhaps it's sufficient to be on anti-CD20 for a while, but not necessarily forever. The question is, what would you do after? Is this a form of de-escalation in terms of perhaps a lesser need to control relapse biology once you've been B-cell depleted for a while and they reconstitute? And what's very interesting is that when you apply BTK inhibitors to B cells, yes, their activation goes down, but also the response profile is shifted, and it seems to be shifted away from a pro-inflammatory, perhaps even a little bit more anti-inflammatory. That is something that we don't have really direct evidence in vivo in humans for, but intriguing enough to think that if B cells coming back after anti-CD20 are exposed to BTK inhibition as the repertoire is being built, perhaps even less of a risk of new relapsing disease activity coming back, allowing you to benefit from the profile on progressive biology.
Yeah, I think you're making a very good point, and I think both in biomarkers, MRI features, algorithms that inform us whether this patient could relapse, is progressing, but also studies that might inform switching. I think this will be very important and very helpful in the future if these agents become available. I think we've covered some of these questions. What do the results of the available phase 2 and 3 trials tell us about Lisa's candidacy for BTK inhibition? I think we would need to break it down by the prior DMT exposure and really understand the numbers associated with prior DMTs, and then these are probably being weaned off prior to the BTK trial starting. But again, switch therapy trials would be very helpful. In terms of navigating the therapeutic sequencing and thinking about the choices that we talked about for Lisa's case, once BTK inhibitors are available, things that I would like to understand is, if she was coming off a B-cell depleting therapy, what is the duration, what is the right timing, what is the B-cell profile that I should be monitoring. So I think these are all questions that I will have if I'm thinking about that scenario. Anything to add, Amit?
Well, things that people have struggled with in the context of switch, of course, relate on one hand perhaps to safety. I mean, you're going to have too much overlap of impacting the immune system. I think with BTK inhibition, it's going to be perhaps not as big an issue as with some of the other therapies, but something that we need more data in terms of people transitioning from one immune therapeutic to the BTK. And the other is control of disease activity. And I suppose that if you're dealing with the issue of coming off a therapy that has been associated with the risk of rebound of disease, coming back sort of with a vengeance, would you consider a BTK as having the profile that may control that? Would you consider bridging? And people have done creative things with bridging, with several infusions of natalizumab even, and so on.
Yeah, so I think much to come, and it's going to be a very interesting time in this field. So I think we've covered a lot of ground, but I think some of the questions that we will continue to ask, especially in our own practices, is which MS type will BTK inhibitors be used in? What stage of disease would they be most effective in? Where do we sequence them or use them in the whole treatment course? Are they first line, second line, or rescue therapy? And then could they be used in combination? I think that's an open question, and maybe something that might be addressed down the road. And then, of course, safety is really tantamount. So what about hepatic risk factors? How should we be assessing our patients as candidates for BTK inhibitors, given some of the safety profiles? And then, very importantly, what do we know about the safety of BTK inhibitors in pregnancy and breastfeeding? So I think these are important questions to consider, especially in our patients who, a large proportion will be women in their childbearing years. And then lastly, would discontinuation of BTK inhibitors result in a rebound? And I think that's an important point that has been brought up. So many questions to still answer and consider. And I think to sort of wrap it up and summarize this section, so we've heard a lot about the role of B cells, microglia, and MS pathophysiology, and this has led to the exploration of BTK inhibitors as a treatment. They seem to have a promising role across different clinical phenotypes, relapsing and progressive phenotypes. And there may be differences in dosing or pharmacological properties that might influence the safety and efficacy of the different BTK inhibitors, and including their impact on relapsing or progressive biologies. So I think we'll now turn to the Q&A session, and we have the opportunity for you to ask us questions. There have been several that have been entered into the chat already, and maybe I'll ask Amit to lead off with a couple of questions to start us off.
We've got some great questions here. Maybe I'll start with some of the sort of broader questions, and then we'll get into some of the more granular stuff. Tanusha, this one is very much up your alley. How do you incorporate biomarkers and imaging into your clinical decision-making across the disease spectrum?
Yeah, so I think, probably the key questions that we've brought up here is I would like to understand what, with any given patient, what their propensity, what their risk is for having a relapse in the next 2 years. I'd also like to understand what their risk for having progression or disease worsening by PIRA, and especially chronic active lesions in the next, say, 2 years. And that would influence my choice of treatments. And I think in terms of relapsing biology, we know that younger age is associated with a higher risk of relapses. We know that NFL levels are associated with a higher risk of relapses, so higher NFL will predict higher risk of future disease activity because they're probably having disease activity at the moment. And then there may be other biomarkers that are coming down the pike that will help to inform us. Now, this all needs to be taken in the context of if you're on a very strong treatment, that things like NFL and new MRI lesions will not be very helpful in telling you whether your patient will relapse in the next few years. I think we do need additional biomarkers, and that could tell us the answer to that question. In terms of PIRA and progressive biomarkers, GFAP, glial fibrillary acidic protein, is sort of rising to the top as one of the biomarkers associated with PIRA, but there have been a number of others that have been proposed and are being evaluated. So I think we may end up with panels of biomarkers eventually that could tell us about the risk of PIRA in our patients, and ultimately we might see risk of relapse, risk of PIRA, both with serum biomarkers, maybe imaging biomarkers, and also with clinical features such as age that could inform us.
Excellent, great, thank you. And you also answered several questions with that very comprehensive response, including how you'd recommend people screen for response to PIRA in clinical practice, and so on. I'll take maybe one here. There's a question here about the clinical implications of differentiating PIRA from PIRMA. Does that impact decision-making in the clinic? And that will also address a couple of other questions that have been brought up here. So I think, again, the notion of attributing worsening clinically to relapsing disease biology versus what is then attributed to non-relapsing progressive disease is what we're trying to get at. And of course, we recognize that clinical relapses are only part of the story. When we incorporate the MRI, we increase the opportunity to identify potential contribution of subclinical relapse biology. Now, subclinical is meant to say that you don't have an obvious clinical relapse and remission or partial remission. But there can be this creep from relapse biology that you see a person now, you see them in 6 months or a year in between, and they're worse. And you're not sure whether this is attributable to relapse biology that was appreciated or not, or to non-relapsing progression. So the addition of the MRI, in my mind, is a more complete definition of the concept of PIRA. If you limit yourself to relapses only, you're not capturing as much as one would perhaps like. But again, the point being that both of these biologies likely exist in most people for much of their experience with MS. And so being able to say that you think there is PIRA shouldn't mean to say that there may not also be relapse biology contribution. We need to do our best to control, and we have the tools to control relapsing disease. And with the enthusiasm that is rightly there to try to make sure we now can address this other major unmet need, we don't want to be compromising on the former. Let's see.
Maybe I could take one. I see an interesting question here. Considering the available results from phase 3 trials thus far with the BTK inhibitors and the FDA response, how do you think trials should be designed moving forward? And I think this is a challenging time in terms of clinical trial design. We have shifting definitions of secondary progressive multiple sclerosis, of understanding how PIRA and RAW fit into these concepts. I think that it really is a discussion with regulators, but in terms of trials that I would like to see are switch studies and understanding the safety and efficacy of switching from all of the agents we've discussed in Lisa's case to a BTK inhibitor. And I think we need to have clear definitions of how we would define their outcomes, PIRA, through clinical measures, and maybe also incorporating some secondary outcomes that could be interesting, digital tools or measuring gait in different ways, et cetera. So I think those are trials that I would consider, and I think we do need to really hone in on some of these definitions of secondary progressive MS.
Maybe I'll take one here, Tanusha. There's a question about the primary outcome of Perseus. Why do we think that primary outcome was not met? I may take an initial stab at it. I don't know the answer, of course, but I think that one of the challenges that we've had is that if you have your control arm doing very little in terms of the biology of interest or its manifestation, it's extremely difficult to see a benefit. That doesn't mean there is a benefit. You have not shown a benefit, and it's a negative study. But perhaps a potential contribution that is more related to populations being recruited differently across trials. And in particular, what had occurred is that there was co-recruitment at a good number of sites to Perseus and to Fintrepid. And you might imagine that if you have a person who's getting worse more quickly, you may be more inclined to recruit them at your site to a study that is pitting a BTK inhibitor versus ocrelizumab as opposed to a BTK inhibitor versus a placebo. And that may have contributed, and people are now trying to figure out the numbers and to what extent that might have been an issue. But you then might imagine that that could have contributed to the patient population indeed being harboring less of the biology that you're trying to target with your therapy and being less able to show a difference.
Yeah, so I could ask one of these questions that has been brought up. Can you discuss your thoughts on preventing, monitoring, and managing liver toxicity with BTK inhibitors? So I think we've certainly seen some of the data around tolebrutinib and others in terms of liver toxicity. Eventually, this will be really a program that might be listed in the product information. But in general, I would want to, with all BTK inhibitors early on, at least monitor liver toxicity quite serially in my patients, probably on a monthly basis, as we are gaining more information about long-term safety parameters. I'd also think about concomitant medications and whether those could introduce additive effects in terms of liver toxicity, and I would want my patients to report any new medications to me and assess their risk-benefit ratio. But I think we'll gain more information over time in terms of liver safety as more data becomes available, both in the pivotal studies and in the extension arms.
Excellent. Tanusha, I'm going to try to tackle maybe two questions in one here, and then would be interested in your thoughts on this as well. So the first question relates to, can we discuss differences between the various disability outcome measures in trials? And the other, considering the available results from phase 3 trials, how would we think of designing trials in the future, perhaps better? So I'm going to kind of put those two together and make the point that, you know, we've recognized, of course, that EDSS, as much as it's been incorporated into sort of our lives in the context of clinical trials, is far from perfect. And to try to capture more potentially meaningful events of disability progression that would not be captured with EDSS, people have considered, for instance, composites. And we've heard results of several trials that include composites. And composites, particularly ones that say you can meet the endpoint if you hit either this or this or this. So either worsening EDSS, confirmed disability progression the traditional way, or meaningful enough increase, 20-25% increase in the time 25-foot walk, or a meaningful change in the 9-hole peg test. It gives more opportunities for people whose progression may be manifesting clinically in different domains, and that makes a lot of sense up front. But there's a risk there that if you happen to have a population in whom the majority of contributors to meeting the endpoint actually don't discriminate your treatment from your control, you end up you're essentially underpowered based on the more informative patients. And you know, we know, for instance, the OHAN study, which used the dual, 2 of the 3 elements as opposed to 3, did so because it recognized that people recruited to that study, many of whom were already disabled enough that they were using walkers or wheelchairs, and the notion of a time 25-foot walk didn't seem like a reasonable thing to do. And it also relates to the metrics and how well each one of those is measured. And you can imagine the noise that might be introduced into a time 25-foot walk if people aren't very careful about, are you using your AFO or not? If someone transitions to suddenly, to needing an AFO, will that actually enable them to go faster safely as opposed to before? And could that introduce noise into the measurements? So we're still learning, I think, but at the very least, we recognize the importance of being as thoughtful as we can about matching outcome measures with populations that we recruit to trials. Any other thoughts on that, Tanusha?
Yeah, I think it's challenging. The measures are not perfect, as we've realized, in terms of the outcome measures for phase 3 trials. Disability measures are not perfect. A lot of inter-rater variability, as well as all of the factors around measuring any gait outcome or really any outcome. So I think additional tools would be very helpful, including imaging metrics, including possibly wearables that could inform what's happening to a patient between their visits. So I would encourage companies to incorporate those so we can gain information that might be useful for future studies. I think a question has come up around combination therapy. So could there be an option for combination therapy with a BTK inhibitor and another drug? I think, of course, the pharmacological profiles would need to be taken into account, and safety profiles, and especially depending on liver profiles with various agents. But there could be an opportunity to potentially combine possibly with B-cell depleting therapy. We talked about a scenario where someone might be dosed with a B-cell depleting therapy and is coming off of their B-cells are coming down, and then a BTK inhibitor is potentially introduced. So these are all, potential scenarios. I think we would need to understand the safety, both around the immediate tolerability as well as infection and other profiles around combination therapy. So I think we're still in early days.
I think so. And actually, a related question is, if BTKs were approved today, how many years of real-world experience do you think we would like to have before considering combination or sequencing? I think that real-world data is important in this regard, but I actually think that doing the studies, doing the trials, sequencing, looking at combinations is going to be particularly important to get the most solid data about both the safety and the transition in terms of efficacy. And these need not be very large trials. In fact, they can be done in a way that is pretty practical. We have some examples historically of such studies.
Great. I think this is a question around, will you expect to use BTK inhibitors for naive patients or patients who've already been on another DMT? And I think there's no requisite that they would need to have been on another DMT before starting a BTK inhibitor. However, a young patient, let's say a 25-year-old who presents with very active relapsing remitting MS, you might consider B-cell therapy or other therapies early on, and then potentially transition them. But of course, we all have patients who present for their first time MS visit in their 30s, 40s, who seem to be more along the Pura and progressive MS course. So that is a patient that I might consider a BTK inhibitor for as a first-line therapy.
Yeah. Tanusha, why are we using teriflunomide as a comparator for our MS therapy trials?
Well, I think it's a comparator that you might win with, so that's one reason. But I think there's practical reasons. If we want to advance and understand the efficacy and really try to advance these agents to clinic, you need to have studies that do demonstrate some efficacy. Otherwise, we will never learn, we will never gain experience with these drugs. Eventually, there might be studies that compare it to other agents, but I think, in order to show a positive outcome in trials, you need to compare it to something that you will be able to do better than.
Yeah. And you mentioned the practicality. Obviously, if you're looking at an oral treatment, it's easier to have an oral as opposed to having to double dummy with an injectable or infusible. But also there are some others like S1P receptor modulators where the decreased lymphocyte counts could unblind, so you want to avoid that. Mm-hmm. And actually, teriflunomide, of course, it's not inert when it comes to relapsing disease, although we think of it as relatively modestly effective. But there's always been this intriguing observation that it might actually impact progression of disability in a way that's a little out of proportion with what it does to relapse biology. And so in some ways, if you're looking at a drug that may have a profile on non-relapsing progressive disease, that's not an unreasonable one to choose.
Yeah, I think those are all really good points and well taken. In terms of dealing with a patient on BTK inhibitors who develops markedly high liver enzymes, what would you do? I'm going to turn it over to you, Amit.
Read that again, because I was...
So how would you deal with a patient on a BTK inhibitor who develops markedly high liver enzymes?
I would stop the drug right away. Yeah, I think this is one of the big questions for us, of course, is, and people, you might imagine, across companies are working very, very hard to see if they can identify something that would predict who the rather small minority of people are who can end up with a very, very serious, even fatal outcome. What I think people are already aware of is that what we've seen is that the bumps in liver enzymes that one would be concerned about, when they happen relatively quickly, and so that requires you to catch them quickly. But they seem to largely happen within the first few months of the exposure, and if you're beyond that, you seem to be at much lesser risk of this type of outcome. And so the question will be, do we embrace the presence of the risk without being able to avoid people getting on it who are at risk? In other words, people have to share the risk, but can we do so by risk mitigation so that we monitor people fairly extensively, such as with weekly blood draws for 3 months? It's a burden, but if there's a promise of a therapy that impacts non-relapsing disease, I suspect quite a few of our patients would certainly consider this. We just need to make sure that we can implement that practically and safely.
Great. Well, I think with that, we'll end the Q&A session. We are here afterwards if you'd like to ask us questions, but now we'll go to the last segment of the presentation.
So we're very close to wrapping up, folks, and thanks for all the great questions. We didn't get through all of them. We apologize, but hopefully this was enjoyable. We thank you very, very much for the attention and for the participation, and wish you a wonderful rest of the meeting. Thank you so much.